Stroke rehabilitation has been referred to as the cornerstone of good clinical stroke care. The approach is very broad with multiple therapeutic interventions, a variety of outcome measures, and input from a wide range of professionals. So when you admit a patient for stroke rehabilitation, you should be clear about the objectives that you have. One is the prevention and management of intercurrent medical complications, early mobilization, minimize impairments, achieve maximum functional independence, reintegrate into home, family, and community, and re-establish a meaningful and gratifying life. So there are certain criteria for admission to comprehensive rehabilitation. That is, patients should have a significant persisting neurological deficit with an identified disability in mobility or self-care, communication, continence, or swallowing. They should be able to consistently follow a single-step command, able to participate in at least 3 hours of therapy daily for 5 days a week, and there should be clearly defined, achievable, and measurable benefits. So if the patient is recovered well, he may continue rehab on an outpatient basis. So there is a lot of evidence to show that early rehabilitation in stroke is associated with better outcomes, it is cost effective, and has a strong positive psychological benefit for the patient. So stroke rehabilitation is not a distinctly separate phase of care, but is an integral part of medical management and continues longitudinally through acute care, post-acute care, and community reintegration. So how early? It should start within 24 to 48 hours of admission if the patient is stable neurologically, and patients should receive as much therapy as they need, can be given and find tolerable. Very early intensive mobilization before 24 hours did not lead to a favorable outcome at 3 months. Early involvement of the physiatrist in the ICU has been shown to be associated with better functional outcomes because multidisciplinary rehabilitation can start early. So the physiatrist can make a long-term plan, take strategies to prevent complications, establish a communication system, initiate a coma stimulation program, mobilize the patient early, and prognosticate. So the rehab team should make sure that the patient admitted for stroke rehabilitation has had the etiology of stroke thoroughly investigated. There are a number of conditions that are associated with a high risk of recurrent stroke that need specific treatment, so the team should make sure that all this has been thoroughly evaluated. After this, the rehab team should make a very comprehensive assessment attending to the whole person, the family, looking at their pre-morbid education, their vocational responsibilities, economic state, vocational interests, hopes, dreams, architectural barriers, and also you should have an assessment of their function. You are looking at not only what is the problem and why is the problem, you are also looking at so what. Identification of the intact functional abilities is necessary so that we can augment them and restore their functional independence as much as possible. So you are looking at their pre-morbid activities, cognition, behavior, and functional status, comorbidities, acute medical and neurological sequelae. You screen their spatial senses so that you can optimally interact with the patient, their cardiovascular status so that you can structure the interventions, look at their joint and muscle abnormalities. Many of them may be on polypharmacy. Are they frail? What is their current cognitive, behavior, and functional status, and their formal and informal social support so that you can set realistic treatment goals. Then the whole team evaluates their functional abilities using the various standardized scales and outcome measures as much as possible. You just today heard about the various outcome measures, so you can use various outcome measures for each of these impairments. And once you have assessed, we make a function-oriented and goal and plan based on the assessments. Goal setting has been shown to increase the long-term benefits of rehabilitation. We need to set goals which are short and long-term goals, and they should be SMART goals. You have heard about it today: specific, measurable, achievable, realistic, and time-bound goals. And it has been shown that if there is engagement of the patient and family, there are regular team meetings, consistent training in a structured environment with constant feedback and reinforcement, and if the training is task-specific, the outcomes can be much better. So the end goal is purposeful functioning, and there are no preset formulas for this. There are various prognostic models to suggest the outcome, but in general, the factors predicting poor outcome include advanced stage, comorbidities, severity of stroke, including severe weakness, proximal spasticity, prolonged flaccidity, poor sitting balance, visuospatial deficits, mental changes, incontinence, low ADL scores, and the time interval from onset to rehabilitation. Some patients are still emerging from coma when they are admitted for rehabilitation. So in addition to a clinical examination, we do neurophysiological, neurobehavioral evaluations using coma recovery scale, the Wessex head injury matrix, etc. Electrophysiological studies may be done and look whether the patient is focusing, tracking, localizing, differentiating between stimuli, are they obeying commands, are they able to use objects functionally, etc. And the goal is to create an environment that facilitate maximum emergence from coma and prevent complications. Rule out treatable causes, provide a quiet environment, start multimodal stimulation, avoid medications with sedative side effects. Some neurostimulants like modafinil and syndopa can be used. Right median nerve stimulation, hyperbaric oxygen have been tried. Orient to familiar and visual and verbal information. Remember that there can be a delayed response time, and sitting and verticality can be achieved during this period. Medical complications occur frequently during the post-acute phase of rehab. In about 60% of patients, 94% of patients with severe lesions. Most common are aspiration pneumonia, UTI, venous thromboembolism, pressure sores, there can be stroke, progression, seizures, etc. Thromboembolic disease, pulmonary embolism accounts for 10% of deaths from stroke. Incidence of DVT is about 20% at the time of rehabilitation, onset of rehabilitation. So all patients should be screened for DVT and prophylaxis can be started, but there can be safety concerns to use anticoagulation due to risk of fall, risk of rebleed. So anticoagulation can be discontinued as soon as the patient is ambulant. And when there is a DVT diagnosed and anticoagulation is contraindicated, there has to be a consensus decision with the neurologist and the radiologist. Inferior vena cava filters can be considered in those cases to decrease the risk of pulmonary embolism. Many patients are admitted with tracheostomy. The question will be when to decannulate. So ideally, when they are able to tolerate at least 24 hours of capping, they are adequately conscious, there is no aspiration or infection, has an effective cough, can speak clear long sentences, and has normal or near normal swallowing, tracheostomy may be safely decannulated. Dysphagia is a frequent effect of stroke. You have heard enough of it yesterday. It occurs in 67% of brainstem strokes and about 28% of hemisphere strokes. In supratentorial lesions, spontaneous improvement is frequent and fast, and recovery occurs within few weeks, whereas in brainstem strokes, there can be a significant impairment of swallowing because of the involvement of nucleus tractus solitarius and nucleus ambiguous, which are located in the medulla, and that takes a long time to recover, for about 4 to 6 months. Some of them may remain permanently unable to support any oral intake. The problems of swallowing we know may be aspiration and a very costly pneumonia, so nasogastric tube feeds may be needed initially. The goal is to achieve safe swallowing and adequate nutrition, and all patients should be assessed by a speech therapist when they are admitted for rehabilitation for the swallowing, and when long-term tube feeds are needed, PEG feeds may be associated with better comfort and better outcomes. So aspiration pneumonia has been greatly reduced with the use of dysphagia guidelines. 49% are malnourished at admission, had lower rates of recovery. It may also be due to decreased cognition, consciousness, hypermetabolism. So routine supplementation of diet can improve the nutritional status. Stroke seizures can occur at the onset or can be within 1 to 2 weeks, or late seizures more than 2 weeks. They are usually associated with large parietal and temporal hemorrhages. Mortality is higher when there are seizures. Early seizures may not recur, but late seizures have a higher probability of recurrence. So in late seizures, you may consider prophylaxis, and in the rehabilitation setting, they may be gradually tapered if there has not been any seizure occurrence, and when the anti-epileptic drugs are terminated, the cognitive status is found to improve. In late seizures, you have to consider treatment with the anti-epileptic medications, and that can be tapered after a 2-year period free of seizures. Continence, again we had presentations yesterday and tomorrow again. It is an unvoiced symptom in 50%, most distressing, associated with severe strokes. 17% may have a pre-existing incontinence, usually resolved spontaneously, but if it is long-lasting incontinence, it indicates a poor prognosis. So remove the catheter as early as possible and institute time voiding and regular emptying schedules, fluid regulation, anticholinergics, etc. And there are various causes for the incontinence as seen here. So if the incontinence persists, you may need further studies with ultrasound and urodynamic studies. Again, bowel problems may include constipation, diarrhea, fecal impaction, etc. And the goal will be, as we heard yesterday, to attain predictable and adequate bowel evacuation, preventing accidents. Sleep-wake disorders occurs in about 20 to 40% of stroke patients. It can be hypersomnia, or it can be excessive daytime sleepiness or insomnia. There can be sleep-disordered breathing. Example, obstructive sleep apneas, which is a high risk factor, can negatively influence the outcomes of rehab. So this sleep disturbance can be because of the involvement of the ascending reticular activating system or various environmental factors, fever, drugs, etc. So maintain a sleep-wake diary, establish a good sleep pattern so that they can participate in the therapy sessions. Timetable rescheduling may be done so that cognitively difficult tasks can be scheduled when the patient is maximally alert. Medications use the lowest effective dose as possible for the shortest time period. Medications like trazodone, melatonin, mirtazapine, modafinil. Modafinil can be used when there is excessive daytime sleepiness. Fatigue is again a frequent and potentially invalidating post-stroke sequelae. It can be subjective fatigue with feeling of weariness and exhaustion and aversion to therapy, or it can be objective fatigue with measurable decrement in performance with repetition of a physical task. This may be the only persisting sequelae that severely limit return to previous activities. Neuropathic pain as well as musculoskeletal pain. Neuropathic pain is frequently underdiagnosed, and therefore you should assess for pain on regular basis and treat actively with psychotherapy, medications, physical modalities, etc. Shoulder pain, 70% occur during the first year. Most important causes are improper handling, CRPS, and various soft tissue lesions. And shoulder pain is associated with poor recovery of ADL, sleep disturbances, higher rates of depression and anxiety. So the most important treatment is to educate the patient and the family and the relatives regarding proper handling techniques and the staff regarding proper handling of the shoulder. Shoulder subluxation occurs in 30 to 50% of the patients. It is caused by the weight of the arm pulling down on the humerus. So treatment is again proper positioning, avoiding pulling on the arm during transfers and use of hemisling, lap board, armrest, electrical stimulation to deltoid and supraspinatus has been found to be useful. Pressure sores are quick to set in, causes a loss of time and finances. It can be life-threatening. Patients in coma, incontinence and spasticity are at high risk. So all strategies should be put in place for the prevention of pressure sores. Now early mobilization, as we already said, can have psychological benefit for the patient. So activities are started passively and then quickly progress to active participation. Activities may vary from passive range of motion to out-of-bed activities. Mobilization is delayed in patients with coma, progressive neurological signs, severe orthostatic hypotension, etc. Fatigability, BP response, heart rate response, etc. give clues to evaluate endurance and decide on the rate of mobilization. Falls and hip fracture can occur during the mobilization phase. So special attention should be given to balance issues, weakness, confusion, patients with visual impairment, neglect, etc. So they are taught to transfer from the chair to the wheelchair to the toilet. Then walking is started, and then ADL training is given. So orthostatic hypotension may occur during the mobilization phase when we need medications like fludrocortisone or midodrine. Mastering safe walking skills is an important objective after stroke, and it's important for the independence in ADL. So therapy is often concentrating on gait re-education. AFO and ambulatory aids like a quad cane or a hemi walker may be needed. In case of wheelchair ambulation, appropriate modification of wheelchair, propelling techniques, propelling with the non-paretic limb, etc. may be needed. Lot of studies have been done to find the effectiveness of strength training, AFO, biofeedback. In biofeedback, the internal physiological events are detected in the form of visual signals and auditory signals. Patients are taught to manipulate these events by manipulating the displayed signals. Then you have rhythmic auditory stimulation, where patients have to synchronize their arm and leg swing with an external rhythm. The rhythm functions as a timekeeper to increase the stride length. Then patients are encouraged to do their functional activities using compensatory strategies or adaptive aids. You should understand the home environment, study their function, assess the function using a modified Barthel index. Remember that there can be safety issues, behavioral issues. Because of the fatigue, frequent breaks may have to be given. Family members, staff, everybody have to be involved in the ADL training so that it can be carried over to the bed and also when they go home. Functional abilities including stooping, transfers, etc. are taught. Poor motor control is the most characteristic impairment seen in stroke. So Brunstorm and Sorner has described the recovery following stroke-induced hemiplegia. We have the different stages of stroke. Most of the recovery occur in the first 3 months, minor recovery after 6 months. Some motor recovery of the hand by 4 weeks, up to 70%. In that case, there is 70% chance of making full recovery. Poor prognosis with no grasp strength by 4 weeks. So there are two types of recovery. One is a spontaneous recovery early after stroke. And then you have the induced recovery occurring later as a result of therapeutic approaches. There are many different methods of physiotherapy proposed over the years, and each one helps to improve motor function to effective control. We have heard about this yesterday, PNF, Bobath, Brunstorm technique, etc. And each one helps to improve motor function. Evidence regarding the type of therapy is equivocal. Now, approaches that use the principles of motor learning, which can promote neuroplasticity, are there. So what are the principles of motor learning? So any activity can be learned if there are significant number of repetitions. It is done with high intensity, it is task specific, tailored and goal directed. It has to be progressive in difficulty, error free, carried over time. Moreover, it has to be highly motivating, ensuring active patient participation with precise sensory motor feedback. It has to be rewarded and integrated into meaningful function. So this motor learning can be augmented by task-specific practice, drugs, neurostimulation, robotic trainers, etc. And that is the basis of recent therapeutic approaches. So in the Carr and Shepard motor learning program approach, the practice has to be task and context specific. That is to learn functional tasks in functional settings. That is, instead of working on standing balance, trunk control, etc., you can work on improving standing and walking tasks as such. An active role of the patient is promoted. Task-oriented therapy for walking with practice at high intensity can be carried out with body weight supported treadmill training. Here, in the initial period when the patients are not able to walk unsupported, the body weight can be partially suspended, and this generates stepping kinematics in the patients, and there is a decreased fear of fall due to the harness, and various physical and cognitive cues can help to improve the kinematics, spatiotemporal and kinetic features of stepping. But this can be very labor intensive because the therapist have to lift and keep the limb above, and it can be quite taxing to the patient, therapist, especially if there is a lot of spasticity and weakness. So robot-assisted gait training is less labor-intensive, and the locomotor interventions can be done with the help of only one therapist. It can be done for a longer duration and increase the amount of practice of stepping behaviors. So training can start earlier after trauma because the robotic devices can generate more power than the human being. This is one of the largest RCTs in robot-assisted gait training in subacute stroke that showed that in the intervention group, more patients in the robotic group could walk independently. Now virtual reality is coming up. So virtual reality is defined as interactive simulations created with computer hardware and software to present users with opportunities to engage in environments that appear and feel similar to real-world objects and events. You can have immersive environments where the patient views the virtual environment in all directions. For example, he wears a head-mounted display where the vision of the outside world is completely occluded. And then you have non-immersive systems when the environment is presented on a single screen. So they can practice everyday activities that cannot be practiced in the hospital. Evidence of neuroplasticity as a result of training in virtual reality is emerging. Then you have transcranial magnetic stimulation, which can alter the human cortex excitability. You know there is high frequency RTMS, which is 5 Hz and above, done on the ipsilateral side to facilitate excitatory circuits around the area of the injured brain, and low frequency RTMS, which is 1 Hz or below, done on the contralateral side to inhibit circuits in the healthy hemisphere, thus reducing inhibition of the injured hemisphere. So current literature supports the use of RTMS for motor recovery after stroke within 6 months. Patients with more severe impairment at baseline benefited more. Then there is transcranial direct current stimulation, which modulates the cortical excitability by delivering weak direct currents over the scalp. Transport 2 is a multi-center trial which showed that it did not lead to further reduction in motor impairment, but it was safe, well tolerated and feasible. You have neuromuscular electrical stimulation, which is therapeutic electrical stimulation done with the aim of muscle strengthening or recovery from paralysis. That is one type. And the second type is functional electrical stimulation to compensate for voluntary motion. In walk-aid system is an example where electrical stimulation is delivered during the swing phase of gait, producing angle dorsiflexion to help leg clearance. Then you can have EMG-triggered NMES, EEG-triggered NMES, brain-computer interface system to trigger NMES. These are all recently coming up interventions. Motor imagery, that is the cognitive rehearsal of movement in the absence of overt activity. It is efficacious in the treatment of post-stroke patients when used as a complement to traditional rehabilitation techniques, but it may not be suitable for those with severe cognitional and attentional deficits. Circuit class therapy is another intervention that involves working in groups and repetitive practice of functional tasks that are continually progress as function improves. There is moderate evidence that is effective in improving mobility for people after stroke. Effects may be greater later in the chronic period of stroke, may be of clinical significance. Vagal nerve stimulation is used with limited success and needs further trials. Now, prognostication of long-term outcome can influence the goal of care, selection of treatment strategies, and expectations of patients and their families. So the TWIST algorithm predicts time to walking independently after stroke based on 2 clinical measures at the bedside. 1 week post-therapy, the trunk control test and the hip extensor power MRC grade may predict whether and when a patient can walk independently within 12 weeks after stroke. And then the TWIST tool was brought up, which predicts when the patients will recover independent walking after stroke. So here the knee extensor strength, the Berg balance strength, all this and the age is scored out of 4. And if the total value is 0, patients are dependent at 6 weeks, 20% are independent at 24 weeks, and if the TWIST grade is 4, 100% are independent at 16 weeks. Therapy of the hemiparetic arm is initiated with ROM exercises, weight bearing, trunk rotation, facilitating mass grasp, activities involving the different and all the finger movements, individual finger movements. Then upper limb robotics. The Armio spring is a passive device. It does not have robotic actuators. It provides varying levels of gravity support and a 3-dimensional workspace and several degrees of freedom. And there are virtual reality tasks and games, built-in sensors, and exercises are tailored to current level of upper limb function. It works on the principles of motor learning. Again, robotics for hand functions are very few, and it helps to improve the passive, active assisted, and active movements of the fingers. So this was a systematic review on the effects of robot-assisted therapy for upper limb function. And there was improvements seen in the upper limb function, but ADL did not improve much. And some of the studies have combined this with NMES, transcranial direct current stimulation, etc. Constraint-induced movement therapy, you know the concept of learned non-use. Learned non-use occurs after stroke in the paretic limb because of pain, because of repeated failed attempts to use the arm, and because of the ease of use of the unaffected arm. So acute non-use leads to loss of motor function and shrinkage of the cortical representation for the affected limb. So here, to promote the use of the affected limb, splint is applied to the intact hand 90% of the day to force the use of the paretic hand and combined with shaping, which means the tasks are made progressively difficult. So this will promote functional reorganization of the brain, but this requires that the patient should have 10 degrees of voluntary wrist and finger extension. The explicit trial was done to study the effects of CIMT. The effect was not sustained at 26 weeks. Then bilateral upper limb training. In the unilateral upper limb training, it is quite difficult to do the training when the patient does not have a certain degree of motor strength. So the contribution of the healthy hand is used to manage these patients, and that can help to get a better recovery. Mirror therapy, it was introduced by Dr. Ramachandran, and visual feedback is given to the individual using a mirror that reflects the non-affected limb to give the illusion of movement in the affected limb. So the mirror neuron system in the frontotemporal region and superior temporal gyrus discharges with the goal-oriented action and facilitates cortical reorganization. It is also useful in visuospatial neglect, pain after stroke, etc. Similar to the lower limb, the predict recovery potential algorithm helps to predict the upper limb recovery based on the shoulder abduction and flexion, the finger extension score, and the age of the patient and the motor evoked potentials. You can predict whether the patient gets a poor recovery or an excellent recovery. Then there are 2 trials done for pharmacology for modulation. One was a FLAME trial, which you know of. For fluoxetine, FLAME trial, fluoxetine could reduce the stroke-related disability. But later on, the focus trial, that is fluoxetine or control under supervision, found that results do not support the routine use of fluoxetine either for the prevention of depression or for motor recovery, and in addition, there is an increased risk of fracture in the fluoxetine group. Then there are certain other studies by the European Federation of Neurorehabilitation who suggested escitalopram 20 milligram per day may be recommended for motor recovery. Then other drugs that have been studied are amantadine and modafinil, which may help for functional recovery and post-stroke fatigue. So this motor recovery may be hampered by various factors. One of them is spasticity. You have heard about the spasticity which can be beneficial, the dynamic nature of spasticity, and there are predisposing factors. You know the goals of management of spasticity to improve motor function or prevent contractures, reduce pain, etc. Management of spasticity you are familiar with. So antispastic medications in stroke should be used only when there is absolute indication because of the sedation and cognitive side effects, and surgical procedures are rarely done in spasticity. There can also be various behavioral issues, and personality change is the most difficult persisting change. So you have to have psychotherapy for this. Various neuropsychiatric deficits including depression, apathy, agitation, anger can occur, for which an ABC charting, various medications and neuropsychiatric opinion may be needed. Post-stroke depression is very common in about 40% of patients, and again we need psychotherapy and a monitored trial of antidepressants like fluoxetine or sertraline. Hemispatial neglect can hamper the rehab outcome, especially if it is persistent, with increasing probability of accidents, lesser ability to do transfers, gait training, etc. And you treat patients with making them aware of the neglected limb and prism adaptations. Movement disorders, we heard about it yesterday, can be hypokinetic or hyperkinetic syndromes. Vision problems with visual field deficits, diplopia, cortical blindness, etc. So patients have to be evaluated by a neuro-ophthalmologist and give glasses for refractive error. For hemi-neglect, you can treat with prisms, patching the deviating eye in case of diplopia. Aphasia, we have heard about it yesterday. And all patients should be assessed by a speech therapist. Some drugs like donepezil, levodopa, memantine, etc. may help in aphasia. Communication devices may have to be implemented when in cases of motor aphasia. Cognitive deficits, all patients, again, the cortical deficits depend on the lesion location, and evaluate the impact of cognitive impairment on rehabilitation and find the areas of strength that the patient can build on. Various cognitive retraining strategies, which we'll hear about it tomorrow. And long-term issues, we need to look at community integration, return to work, sexuality issues, carer issues, post-stroke dementia, equipment needs. Secondary physical problems can occur like excessive spasticity, changing pattern of ambulation, etc. So see that they can climb stairs, negotiate ramps, use public transport. They are able to do a community outing and practice in as many contexts as possible. Return to work. Factors that influence return to work are more psychosocial, and follow-up and support has to be given throughout the employment, and there are problems with maintaining stable employment. Sexual relationships, decline in sexual activity following stroke is common, and dissatisfaction, there's high dissatisfaction with sexual function, so this has to be addressed. Carers and families, family you know is the crucial asset to the patient. There can be anxiety, role reversals, a lot of restraints in social life, safety and respite needs, need to interact with peers. So family-centered rehabilitation has to be carefully looked at. There is possibility of neurodegenerative disorders following stroke that is high, and treat the vascular risk factors, use medications like memantine, rivastigmine, etc. A comprehensive stroke care is incomplete without giving rehabilitation in the long term, maybe by community-based rehabilitation, and there is a reasonable evidence that active rehab late after stroke can lead to significant benefit. Follow-up methods have to be considered, either home visit, OPD-based rehabilitation, or a CBR, tele-rehab, etc. And stroke rehab definitely improves immediate outcomes as well as long-term outcomes. The survival, independence, and community re-entry are maintained 5 to 10 years after stroke. Quality of life is better with those who had been in stroke rehab. In conclusion, there is need for medical direction, early initiation of therapy, teamwork is crucial. It should be directed at specific trainings of skills and functional training. Psychosocial skills issues are very important. Family involvement has to be carefully considered, And this is, rehabilitation is the end of the beginning of a new life. So it involved resuming as much as possible former roles in the family and with friends and finding ways to live a meaningful life in the community.
My question is, in some patients with acute or subacute stages, especially in hemorrhagic stroke, the BPs are usually like 150 by 100 or say 160 by 100. So are there any guidelines whether they should go for the rehabilitation program, especially in the physiotherapy department, or any set values that we should be chasing for that? Like the BP should be controlled. Sometimes they are not controlled well, so that.
Ideally, it should be controlled, but in certain conditions like carotid artery stenosis and all, you keep it at a particular level, and usually discuss with the neurologist and get into a consensus based on that.
Ma'am, my question was if there is any part of therapy that needs to be avoided. That means usually the therapist reports to us, to a PMR specialist, that the BP is higher, so should we withhold the therapy for some days, or should we, avoid certain things? So any advice regarding that? Any part to be avoided?
So you try and control the BP to the permitted level with addition of antihypertensives or adjusting the medications. Sometimes it has to be kept at a higher level to ensure adequate perfusion.
I am Dr. Lakshmi from AIIMS Bhubaneswar. Ma'am, actually, you had given a criteria for decannulation in tracheostomy tube patients. Ma'am, is there a specific size of which we should consider this decannulation? Like in our department, we do downsizing initially, and once it's at around size of 6.5 uncuff, then we do decannulation. So if all the criteria is met at a higher size, can we try decannulation then?
Usually it is downsized and then corked, and you cork it for few days and then get an ENT evaluation to see the airway and then decannulate.
The least value should be attained and all the criteria should be maintained. Thank you.
Thank you.